first, thank you so much for inviting me to this podcast. I love sharing knowledge. I love just talking about fertility in general. So thank you.
Thanks for
And
coming.
so, of course, so I will first start off by saying I'm a nurse. I'm a nurse researcher. I'm a nurse scientist, hopefully nurse researcher entrepreneur one day. I'm still working on that now. But after going to Boston College for nursing school, I moved back home to Connecticut and I was an ER nurse. And I loved the fast-paced life. And I was just thinking, maybe just become a nurse practitioner and stay in the acute care, urgent care setting, or just research different things related to asthma. That was actually a passion of mine because I worked mainly in the pediatric emergency department, saw really bad asthma cases there until one day I woke up with really bad right-sided pain and I became a patient in my own ER. And after several tests and scans, they're like, okay, Maureen, you have this huge mass on your right ovary. And I ended up being evaluated by GYN oncology. So cancer doctors for reproductive health things. So they'll talk about cervical, ovarian, uterine cancer issues. And I was afraid. I had no idea what was going on. And so the next day I went into surgery so they could take out this mass and test it. And then I come back out and they're like, oh, great. We were able to save your ovary. The mass came out. It didn't look, abnormal. We're still going to send it to pathology. But you were able to keep your ovary. And I was like, okay. I was like kind of like fuzzy headed and stuff. And I ended up being home for 6 weeks recovering because I ended up having to have like external incision with it. So I couldn't work and lift patients and all that. And I kind of, one day it just stuck with me. I was like, I was able to keep my ovary. There was a risk of me losing my ovary. Like, I don't remember them saying that in the pre-surgery consults. And it made me think, what if I did lose my ovary? Would I be able to have kids? And then I just started looking up random things. And there was one New York Times article about someone just mentioning they had infertility as a Black woman. And there was no published research articles at that time. And so that's what actually led me to Winston-Salem State, because they had this amazing bridge program. It was a partnership with Duke University School of Nursing, where it was to increase the number of underrepresented researchers. And so I ended up applying to that. That's where I became a family nurse practitioner, and then met my great mentor, Dr. Eleanor Stevenson at Duke, who studied infertility. She was one of very few, maybe 2 or 3 at the time, nurse researchers looking at infertility. She has since pivoted to male infertility, but she supported me in helping and developing the knowledge. That's what a PhD is about, developing knowledge, having it out there about Black women and infertility. And ever since then, it's just been wild how much attention and research and all that was happening at the same time, because this has been a problem for decades. And it has definitely flown under the radar. And I did a bit of work on the historical and sociological context too, about how
it's very interesting.
Because Black and brown women are often seen as having too many babies. And so then when you get into, there's a subgroup of women who know they cannot get pregnant or stay pregnant. There's just a lot of stigma and shame that had to be disentangled and brought to light.
Yeah, I thought that's really interesting to say that we are thought of as having too many babies. And then on the other hand, we have this issue with those who are either not able to have babies, having this fertility disparity, or the disparity of having children, and what's happening in the birthing units and how there's disparities there. What's been the big aha moment? What's the biggest differentiator that you've learned about Black female fertility or infertility compared to other races?
Yeah, just overall, we've been at the bottom of the totem pole since, the beginning of this country starting with slavery. Our bodies were overworked because we had to produce. We had to produce a lot of children. we're definitely disrespected in terms of our bodies, you know, whether by slave owners and just being like on the fields in general. And then a lot of my research has kind of taken me into just following what the trajectory of Black women's health has been. You know,
Mm-hmm.
before we had to mass produce, and then, okay, boom, slavery ends. And now instead of giving us the resources to take care of our children, we're just, you know,
Yeah.
systematically, you know, excluded from that. And then now that's where you get, well, you have too many kids. Why do you have too many kids? And then you go into like the, you know, 70s and 80s of just general reproductive rights and stuff. You know,
Mm-hmm.
there were Black women at the forefront, but at the end of the day, the focus was definitely white women in America and getting them their reproductive rights and shaming us in the process as well.
Yeah.
And so then you get into today, and, you know, to have, you know, inner city girls being the ones that are most affected by teen pregnancy, not even just getting pregnant, but the resources that they're given afterwards. I've
Mm-hmm.
definitely seen that difference as well too, in terms of resource allocation. And then we finally are able to get pregnant, and then we're like risking our lives, right? Having children
Mm-hmm.
in these hospitals by staff that are not understanding us because they don't understand our cultural context. They don't understand the ways that we might exhibit pain. And it's a spectrum, not to
Yeah.
overgeneralize for sure. But even in my own, like I have a 2-year-old son, I was terrified to give birth. But yet this is my area. I completely understood and knew, you know, the processes of, you know, preparing
Yeah.
for pregnancy and all that. And I understood the terms and the jargon and the lingo, but it was still a very, you know, jarring experience highlighting I am a Black woman, and there's just a
Still,
level.
it's an
Yeah.
inherent fear that comes along with it. I have a 2-year-old too. But
Mhm.
Matt, I ask, how did you choose to birth? Were you in a hospital setting or how did you choose?
Yeah, so I was in a hospital setting. That, and I'm open to all different types of practices and all that, as long as you feel safe in
Mm-hmm.
that and you fully understand the medical, you know, repercussions of wherever your status is at that point. If you're good,
Mm-hmm.
head down, all that, you're great. For me, being fearful, it was part fear that kind of brought me to the hospital, but part like, okay, I just want the resources nearby.
Mm-hmm.
Like if we need to do like a crash section, I want to roll down the hall and I have to travel to the hospital.
Yeah.
And so
And a
that
lot of
was,
people, a lot of women, I think, feel that way. You know, they
yeah.
want to be near. And you also were uniquely prepared, you know, to be
Hmm.
in that setting where like the terms are not going to fly over your head. Like you're going to completely understand what's happening and what the protocol should be. So,
Yeah. Like I could
yeah.
read the fetal heart monitor strips too. Like, we don't got no good dips and pips. Well, you know what we doing here. So,
And I mean, that's so important because I think, like to your point, a big thing is that Black women are not uniquely prepared for these scenarios. They don't know much about a lot of people, like you said, there's a spectrum that don't know much about maybe medical terminology or the processes that should take place. And then you have these fear tactics that come in, and you're already in duress, right? You're already in a state of
hmm.
like vulnerability and duress that you've never been in before. I don't know about you, but like I didn't get nervous about having a baby until like month 8, until I realized like this baby has to come out of me. Like that's when I started to really panic. And you know, the whole time I had, of course, been nervous about stillbirth and the mortality.
Hmm.
I had a baby during the pandemic, as did you, and it's like that in itself, right, was nerve-wracking enough and going into a hospital setting, but then like the possibility of my partner not being there and
Yeah.
who's going to advocate for me. And I grew up with parents that sort of like touched the medical field. Like my daddy worked in radiology for a long
Mm.
time. So like I at least grew up hearing certain terms, but they're not specific to this particular situation, right? So
Sure.
I feel like I'm probably like more prepared to ask questions than some people, but even then it's like I don't know birthing me. I have no
Hmm.
idea what I'm going to be like during that state until you go through it. Like how much can I advocate for myself? You know, you don't even sure. Um, so yeah, it's a very unique experience, and I feel like you're told to just go to the hospital and give birth. and no one tells you how to give birth. No one tells you,
Mm-hmm.
I mean, unless you've prepared yourself and you have like a doula, or you've asked questions about how can I prepare, then you really don't even know how to push. I had a friend who told me like I didn't know how to push, and I didn't realize I didn't know until I got there. She was like, I
Yeah.
didn't realize I didn't know until they told me to push, and I was like, I don't really know what to do. Like,
Yeah.
and you can't learn, you can't learn in that environment at that moment.
Yeah.
So I was like, wow, I never thought about that. I had a home birth. Um,
Mhm.
so different experience. But you talk about the psychological factors
Mhm.
around fertility and around birthing, and I think it's so important because I never realized that safety was key to a lot of this, like the importance
Mhm.
of feeling safe and what does safety look like. I think we use safety as like a general term, and it's like, well, what does that look like? Not only for you as an individual, but as a collective of people. It's like, what is actually safe? Um, so does your research touch on like how women
Mhm.
can better prepare for this fertility journey and like what they should be asking or should be doing?
Yeah, so right now I'm actually phasing into a phase of a piece of my research that's specifically looking at preconception health
Mm-hmm.
because I'll tell you more about my actual dissertation. Uh, I really enjoyed doing it. It was a mixed method study, so I looked at chart data and did interviews with Black women who were in the state of Maryland, who went to this really huge practice.
Mm-hmm.
And I was able, out of a random sample of 3,000 Black women who went to this one practice, I was able to look at about 400 charts. And then I interviewed 13 of those women, just talking about, what brought them to the infertility clinic, what made them actually choose to or not choose to go with a specific treatment plan. And
Mm-hmm.
one thing I noticed on the front end, there was these massive delays of getting into infertility treatment. By definition, it should be 12 months of you not being able to conceive after consistent cisgender heterosexual intercourse.
Got you.
And if you are under the age of 35, if you're over the age of 35, 6 months. Like at 6 months, you still are not getting pregnant going.
Mm-hmm.
These women on average were waiting like 3, 4, 5 years, some
Oh,
many
wow.
10 years. And I was like, what is going on? Why? And these were like higher socioeconomic status women, very well accomplished. They went to their annual primary care or GYN visits every single year. Part of it was just not disclosing. The other part, for whatever reason, they're not getting the referrals to
Oh.
reproductive endocrinology. Another part was just their own stigma and shame. But I did
Mm-hmm.
find that the women, there was though a group of women who like it was less than a year and all that. I'm like, hey, you were the outlier in the situation. Tell me more about what you did. And a lot of it was just asking questions of their friend groups, of friends of friends groups and
Mm-hmm.
stuff.
Yeah.
And really being transparent. So there was just a lack of transparency uh, in terms of like feeling that internal stigma. And I'll never forget, like 3 out of the 13 women would say, hey, you might have a hard time doing this study because there's not many of us. And I had to remind them, no, I actually found you in a random sample of 3,000 Black women in this single state who go to
Oh,
this fertility
wow.
clinic. And so there's just overall that isolation aspect. And so fast forward to now, I'm working on publishing a paper. I interviewed 10 primary care providers and I talked about like maybe their own like knowledge, attitudes, and beliefs of infertility. How do they manage patients? And overall, it was a wide range of responses that I've gotten, but for the most part, a lot of them were not as knowledgeable and they weren't really sure of when to refer to
Mm-hmm.
infertility specialists. Um, but I've kind of realized moving forward, women need to be empowered and really told multiple times, even when you're talking about giving birth and pushing and all that. Um, we don't really learn much in health class. And if we do, our minds are all over the place. So there needs to be that continued uh, access to knowledge
Mm-hmm.
for women of how do you prepare for pregnancy, because there is a very specific way that you have to
Mm-hmm.
prepare. Looking at your own blood pressure, being active, um, you know, taking your vitamins ahead of time, doing genetic testing to understand what is in your family
Mm-hmm.
lineage, which could either influence fertility, like your ability to get pregnant, or the outcomes medically of your own child. Um,
Mm.
like I have a sickle cell trait.
Mm-hmm.
And so that's going to make me wonder, in the future, who am I gonna, be in partnership with, and making sure that I ask that partner, hey, can you get genetically tested and all that? My son's father, he has sickle cell trait, and he knows that I'm sharing this as well too. And so thankfully our son doesn't have any of the traits. He was in that,
Oh, that's
one,
interesting. I
two.
didn't know that was like genetically possible. I thought if two people had the trait, you automatically.
No, yeah, that
That's
that goes back
interesting.
to Punnett squares and in high school
Yeah.
science. Yeah.
High school genetics, which I took. I don't know how to tell you what I
Yeah,
got in that
yeah.
class, but no, I did pay
Yeah,
attention. But
so
no, that's interesting. Yeah.
no, 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 no. It's there are some things for sure. I don't think we use calculus every day, but those Punnett squares, it does come back to get you in terms of recessive and dominant traits and all that. And so a lot of it is just having a full profile of your health now and preparing for the future. And so yeah,
And
that's
that's good
hopefully going to be
information.
my future work. Yeah.
That's good. I don't feel like a lot of people when they're dating or thinking about who they're going to have children with ask those questions, and it almost
Mm-hmm.
feels like, oh, maybe I'm being intrusive, or does that really matter? And it absolutely does. It
It
absolutely does. my
does.
husband my husband was offended when when we started talking about getting married and the possibility of kids and everything, and I was like, well, I need to know more about like your family, like
Yeah.
like just medically, I would love to know more about, are there any, and sickle cell, like, like a lot of Black families, it does run in his. So it was, a point of concern, but I don't think most of us ask those questions. So that's good to
No.
point out. In what other ways can women be more proactive about their fertility specifically? Like maybe
Hmm.
they don't know if maybe they're not pregnant and they're not doing it right now, but if they want
Hmm.
to plan, like when should they start and what can they do?
Yeah, first is defining your goals. When do you want to become a mother, ideally? Um, and I could talk about this for years, but but what is your idea of motherhood? Does it have to be in partnership with someone else? Do you want to be a single mother by choice? Are you open to that? Is there a certain, amount of money you want in your bank account beforehand? Then you will start planning from there. But from today, from the moment you hear this podcast, start thinking about your long-term goals and start looking at it holistically for sure, whether it's financially, emotionally, and socially, like why you want to be mother, but then
Mm-hmm.
physically, the physical thing is super important. We
Mm-hmm.
often see these headlines, and I feel like they never go in depth of like, Black maternal mortality. It's really bad, and people are often dying from preventative issues. And
Mm-hmm.
they often blame the provider in terms of like pointing out certain mistakes, right?
Mm-hmm.
And yes, that is very important, but there's something that you yourself you can do to prepare your body
Mm-hmm.
ahead of time, in terms of if you have high blood pressure now, more than likely you're going to have like, you know, uh, hypertension during the pregnancy, which could lead to preeclampsia, which can lead to seizures and all that. So,
Got you.
getting that in order. Um, Obesity and high weight is not necessarily a diagnosis itself, but if it influences other factors in your life,
Mm-hmm.
then yes, then you have to address that and lose weight prior to having a pregnancy, because you need to gain weight during a pregnancy. Um, and it could be, really challenging if it, prevents you from being able to work out and all that and breathe
Mm-hmm.
properly. If you have asthma and all that, there's all these different factors that come into play. So today, define your goals, but then understand where you are physically. Go get a physical, go get blood work.
An
Um, you know,
assessment.
yes, vitamin D levels. You know, if you're not necessarily sure what your fertility capacity is, you can get labs to look at your ovarian reserve. There are certain offices you just have to call around where you can do a follicle count, kind of like
Okay.
at the peak of your menstrual cycle, just to see, okay, how many eggs do you have right now, just realistically, without any hormones added and all that. What are you working with here?
Mm-hmm.
And then, yes,
Let's talk more about that
yeah.
though.
Mhm,
The exploring the follicle count is, and
mhm,
I don't know if you have the answers to this, but like, do you
yeah,
know what type of clinic should they be going to ask those questions? And like, do you know what that investment looks like? Or
yeah.
do they provide education? Like once you receive those tests and the
Mhm.
results, are they providing education around what that means for you and what next steps might need to be?
Yeah, so unfortunately, in a non-socialized healthcare system, it varies state by state.
Okay.
If here I'm in Connecticut, honestly, this is Connecticut and Massachusetts. If you have private insurance, you're golden. You can go to a fertility clinic and just have a baseline assessment. I often promote a more comprehensive assessment. You see a lot of these companies kind of not selling you, it's their product. They are like, okay, just get your hormone levels tested. As Black women, that's definitely not going to be as comprehensive because we experience fibroids. We need to know, where are these fibroids? Endometriosis is like, are the tissues of endometriosis in a place that would prevent an egg and a sperm from implanting in your
Mm-hmm.
uterus? And so whatever state that you're in, call your insurance company to
Mm-hmm.
see if you have infertility, a comprehensive assessment like coverage. And also, it might not necessarily be your actual insurance company, it could be your job that has just added on this benefit. So if
Mm-hmm.
they don't have it right now, advocate that they have it. And then, right now, if you were to do some advocacy work, it would be put into play hopefully by like 2024, because you always have to wait till like the next
A
year.
cycle.
Yeah, for insurance. Some primary care providers or OBGYN practices will offer some fertility testing, and they'll offer some preconception health counseling appointments. So it's different from your primary care where they're, seeing if you need a colonoscopy, a pap smear, and all that stuff.
Yeah.
That's more of like the primary care preventative health, like a preconception health counseling appointment would really
Mm-hmm.
go into asking more about your menstrual cycle. When do you want to plan? Based on where you are right now, can you wait another year or two, or would you have to look into, maybe starting some fertility treatments right away? Uh,
Mm-hmm.
I am a huge proponent of freezing your eggs, and that it can
Really?
be a process where, so basically, when you freeze your eggs, it's not like an embryo. There might, and I say that because Black women, we have that spiritual context that I
Mm-hmm.
also respect and completely value. Um, and so freezing your eggs is just, going through the process of stimulating your ovaries to produce um, a higher amount of eggs, and then
Mm-hmm.
they are extracted from an infertility office and this whole procedure, and then they're frozen. They are
Mm-hmm.
frozen and preserved. And so if you freeze your eggs at 25 and then you end up using them when you're 35, at that moment you're using 25-year-old eggs. And so you kind of have that vitality and, great DNA that's not as fragile as, if you were to wait in your late 30s as well. So often I
Got
do hear
you.
Black women starting the process of freezing their eggs much, much later in their 30s, or in their early 40s. And over time, the DNA, your DNA in your actual like gametes, or they call it their
Mm-hmm.
eggs, or even in the sperm, it starts to break down and it's more fragile. That's why you end up getting higher rates of um, certain developmental disorders like Down syndrome, Fragile X, and all those as you get advanced maternal age that they used to call geriatric pregnancy, but
Yes. Just so rude.
it was just so rude. But basically, now the lingo has caught up with the times, but there are some real health, challenges that are just seen in women who wait longer to have children.
Yeah. I'll be 35 on Monday, and I'm like, am I
Happy
I'm
early
pregnant.
birthday.
Thank you. And I'm pregnant. I'm pregnant now. And I'm
Yay.
just like, am I geriatric?
Yeah.
Like, I feel okay. But so
No, you're not.
you suggest freezing your eggs in your mid-20s. Like that's when, which
Oh,
I mean, I
it's
know is
probably earlier.
difficult.
Yeah.
Oh, the earlier. Yeah. I
Yeah.
know the cost is always a factor. I considered freezing my eggs. I was about 28
Hmm.
when I was thinking about it, and I didn't have my first child until I was 32.
Hmm.
Um, but cost was definitely a factor. And it seems like they're becoming a little more like solution oriented with like ways around affording this, especially through employers and benefits and things of that nature. But
Hmm.
if you are not, you know, if you don't have that benefit offered to you, I'm not sure how many resources exist, outside of that.
Yeah.
Um,
I interviewed one woman for my study, and she made it so plain, where she was in her 40s now trying to conceive. And
mm,
she said, I wish I would have froze my eggs earlier. And she's like, I know it's a cost, but if you could divide the yearly, storage fee, I'm just throwing out a number, it's very different state to state. It could be between $2,000 and $4,000 a year, right? To store, maybe. Some places it's much cheaper as like more people access, they definitely made it cheaper. But she was like, I wish I thought of it as like a car payment. I
got it.
pay big amounts for my car because I want that reliability. I want a car that's not going to break down. I want, that ease and convenience. So she
Mm-hmm.
was like, the same way I treat it like, I want the ease and convenience of hopefully getting pregnant. It's not your 100% surefire way, right? But it
Mm-hmm.
definitely helps prevent some of the stress that might come later on with waiting. But
Yeah.
overall, it's one of those things, again, you have to maybe prioritize is if, when I go back and talk about the goals, if I really
Yeah.
want to be a mother, what am I going to do to make that happen? And that might be taking on that expense and building that in my budget.
Yeah, what are the steps and adding that, knowing that cost and adding and preparing for that cost, which I'm a total advocate for.
Hmm.
You can't have these things that you need or want if you don't know what the number is. You can't prepare for it. So I think it's important to call around and get quotes and just know what you're getting into. So we talked about preparing, the step of freezing your eggs. So let's say I've done that, I've prepared, I've frozen my eggs, I'm now ready.
Hmm.
Um, what happens during this conception process? What happens when it's time to actually go in and have the IVF process, or what methods are you using to actually get
Hmm.
pregnant?
Yeah, so it all depends. It's very individualized. And one, sometimes people freeze their eggs and they don't even need them. They're able to conceive on their own and they're
Mm-hmm.
fine. That's like best case scenario. It's almost like life insurance, right? You don't, or actually car insurance more than anything, because sometimes you won't even use it, but you still pay for it, right?
Mm-hmm.
Um, so, assuming that you're not able to conceive with your partner in those time frames, then you kind of go in and get a full evaluation. Now they're going to also assess your partner. There's a lot of male factor infertility. That's a whole another dissertation project that someone can undertake because, think about, I always tell people, think about the aunties and uncles who never had kids and they just like love on other people's kids. That could have been a male factor
Mm-hmm.
situation too. So anyway, so they'll do a full assessment, kind of figure out what's needed. Sometimes there's different supplements or medications they can, or procedures that they can do for the male partner, just to help with increasing the sperm count if that's like an issue, and like potency of their sperm, and hopefully understanding that profile a bit better. And then likewise, it depends. Sometimes you could have hormonal factor
Mm-hmm.
infertility. It could just be like a disconnect between like your pituitary and your ovaries, and that whole feedback system. So then you have to take medications to help correct that, or it could be structurally. Sometimes people will just need fibroids removed,
Mm-hmm.
especially if they're, right, at the top of the cervix or something like that. So that wouldn't even allow for sperm to kind of come in and meet the egg.
Right, yeah.
So it all depends on what the issue is. But unfortunately, there is a subset of people who have unexplained infertility,
Mm-hmm.
where we doing all the tests, the follicle counts look great, structurally everything is okay, the sperm is great, and so that treatment plan will just be different. It could start with intrauterine insemination.
Mm-hmm.
That is where they take the sperm, they kind of wash it down to the most like potent sperm, and then the female partner either usually takes medication to help stimulate her ovaries as well, and then they're literally just timing the release of the egg from the ovary, and then they're shooting in sperm, or it might have to be IVF. Where sometimes the IUI doesn't necessarily work sometimes, and then they kind of move into that, or the quality of the ovary, the eggs, and the quality of
Mm-hmm.
the sperm are just so low. Sometimes they do just jump to IVF because that would be the most effective option.
Got you.
And so, yeah, and so in vitro fertilization means that fertilization is occurring outside of the body. So they take the egg, they take the sperm underneath the microscope. Really great embryologists who are kind of, taking on that portion, and they
Mm-hmm.
watch the embryo grow over a certain amount of time frame, and hopefully within a week or so, you have a quality embryo that you're able to, basically transfer back into the uterus, and
Mm-hmm.
then some time passes, and then you'll do blood work to see if you can confirm pregnancy at that time or not. So
Got you. Okay.
yeah, it's very involved. It all depends.
It all depends on your
uh,
personal needs, but thank you for breaking that down. I
yeah.
think a lot of people just think about IVF, they don't think about IUI, and
Hmm.
truly understand like when it's happening internally and when it's happening externally, until they're like in that scenario. I think the thing that's most popular about IVF is the cost, is also what you hear about is like the
Yeah.
cost, but the process and understanding what's happening is also really important. So thank you for breaking it down.
Yeah, no worries. And IVF, sometimes it's not even an option for people. Sometimes just getting the fibroid removed, boom, within a
Mm-hmm.
couple months after healing and all that.
And let's talk
Worth
about
it.
that because you mentioned like your experience and um, what you recalled pre-op versus like post-op. And I've heard this scenario a couple times where things are explained pre-op and then post-op. Of course, when you go in, things change. Um, but there are scenarios where I've heard women come out and like, their ovary is gone, it's been taken, and it wasn't
Mm,
clear. And it's also providing this information to patients who are like, post-op and coming out of anesthesia and these understanding.
yeah.
How can women prepare for these surgeries? And like, are there any questions that they should be asking pre-op and post-op?
Yeah, part of it is really just saying, hey, what are some best case and worst case scenarios here? Like really asking, okay, because I've seen it before. I'm in healthcare,
Mm-hmm.
and you think it's going to be one thing, and then man, you open it up, it's actually way more involved. Um, we didn't have, like, of course, like huge surgeries in the ER, but you think it's going to
Mm-hmm.
be one thing, and things change, and so really just asking what is the full gamut. And sometimes providers, they definitely don't give people benefit of the doubt to kind of understand and not be
Mm.
afraid of like that 1% chance of this or that.
Yeah.
And so yeah, like I think even just saying like, look, like I get this is what's happening. You should be able, always, 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 you should be able to effectively communicate what procedure or what outcome is going to happen. So if you don't get that, first get baseline understanding. I recently went with a family member who doesn't, English is not her first language.
Mm-hmm.
I'm Haitian. And they're trying to explain congestive heart failure to her. And I turned to her and I was like, do you get what's going on? Can you say, like, what is it about your heart is happening? And then
Yeah.
she repeated it, and I was like, okay, we're good. So whatever like medication, and it can be daunting, right? Sometimes providers, nurses, and all, and these are my colleagues, and I'm talking
Yeah.
about them. They'll be like, "Oh, any questions?" But then their hands already at the door. The door's kind of already like halfway open. Like,
Yeah.
so sometimes you could be like, "Oh, do they really want me to ask this question?" No, ask the question, get baseline understanding, ask for the different alternatives of what could or could not happen, and then truly assess: Are you okay with that?
Yeah.
Um, and unless it's like a life-threatening emergent situation, like you might not, you should have the time to kind of mull that over and think about
Mm-hmm.
it and stuff. You know, but overall, just really trying to understand what are the options and what are the repercussions of those options. Like maybe looking back with this cyst, yes, it was very painful. I ended up having ovarian torsion, so like the blood flow could have been compromised to my ovary. But if
Mm-hmm.
there wasn't that torsion, maybe I would have stopped and said, maybe I should get more teaching on freezing my eggs from that ovary, just in case I
Yeah.
lose it. Um, but yeah, in that moment, I definitely, looking back now, it wouldn't have been good because I could have risked losing my ovary
Mm-hmm.
because of the compromised blood flow. But if it's maybe a non-emergent situation, whatever that means for you, consider your options in totality.
Yeah, and that's good. That's good. I don't think a lot of women, I think once you get to that point where it's like you're in need of surgery, I don't think a lot of women think about, oh, let me stop if it's not an emergency, and let me consider like, well, in what ways can I activate other options from
Hmm.
this point forward? Like, should I freeze before going into surgery? And I think that's important to call out. Yeah.
Yeah, for
Well,
sure.
thank you so much. This has been a wealth of information. I have these conversations about motherhood with women all the time, and there's just so much we don't know. And to your point, these women are, socioeconomically, like they're educated, they are working, prepared, they have resources, they just don't have the knowledge around these
Hmm.
nuances of this topic outside of what we see in mainstream media, or like you said, what you hear from a friend of a friend. And they're trying to make these ultimately life-changing decisions. And it's like, you need to be well informed in order to make these decisions.
Yeah.
And like, where do I go to get this information? Because sometimes you have, on average, like 15 minutes with your physician.
Hmm.
So if you're not writing things down, before you get in there, if you're not really like planning out to make the most of that visit, sometimes you miss things. And people are very hesitant to follow up with questions. They don't want to be a nuisance. They don't want to be a bother. I always encourage women to like write your questions down before you get to the doctor. Like, really think
Hmm.
about the things that you want to discuss while you do have them in your presence, and don't be afraid to follow up and ask more questions. So
Yeah,
yeah.
and don't feel like you're a nuisance. If you do feel like you're a nuisance, then maybe you need another provider. Because at
Very
the end of
true.
the day, yeah, at the end of the day, they still getting that money for that visit, whether you ask or not. So why not
Very true.
maximize your money? Think of it. I sometimes I can, think of money too much, but I'm like, no, no, no. If I'm paying for this service, whether my hair, my nails, like I need to like it, you
It
know?
is a
And
service.
so,
At the end of the
yeah.
day, it is a service, and it's not a courtesy. It's not like they're volunteering their time. I mean, I guess in some scenarios they are, but most scenarios they are not.
No, not with private health insurance. No, we're paying for
Yeah.
this in
You're
multiple ways. Yeah.
paying for this. Well, thank you so, so much for
Of
being a
course.
guest. Is there anything that you want to talk to people about, or
Mhm.
ask them? Do you have any needs out there, any research that you want people to check out, that's
Mhm.
new for you?
Um, so wait, in terms of what they need from me or
In terms of what you
um
need, research wise, or is there a
mm,
way that people can return the favor of you providing
oh,
so much information today?
yeah. I mean, I have a link to like my research articles, so checking those out, view counts help. And then in the future, this preconception health project, I'll definitely be launching that soon. It's a survey. It should take about 30 minutes, and people will be incentivized to take it. So I'll send it to you, and hopefully you can
Hmm.
send it out to your listeners as
Yes.
well, just so they can, really be a part of the research. One way also that Black women's health has not been, um, prioritized is because we're also not being involved in some of these research trials. And
Hmm.
yes, it can be invasive with certain medications and all that, but you'd be surprised the amount of pushback I got just to do uh, a 30 to 45-minute interview with Black women. They're like, I don't want to share my business. And I really had to just say, like, no, sharing your business is helping the next generation. It's helping the current generation, just by putting it out there. We'll keep you anonymous in all your responses, but those lived experiences, they will do worlds of wonders. So I'm challenging anybody, even if it's my research project or another one, if they're just asking you to talk about something, sign up for it,
Yeah.
um, and just share so we can build quality science and quality decision making, based on actual facts and not presumptions or other groups that don't experience life the same way that we do.
Very true. Very true. And when you complete this next round of research, we'd love to have you back to talk more about your findings and what you've learned. And yes, send it to me. I'll definitely share it with everyone. I want women to become more proactive, Black women in particular, to become more proactive about their fertility. So thank you so much. We really appreciate you.
Thank you for having me.